Hello, everyone, and welcome to a version of an Unfiltered podcast, but not so much because we have a really exciting expert with us today. Cindy Krafft and I have known Dr. Jason Falvey for 10 years minimum, hung out with him, had a couple cold beverages, but I think that when you get to know Dr. Falvey, you're going to be so excited about what he does in the home health research space. And I'm going to give him a minute to explain what home health means to him and how it relates to home health.
All right. Well, thank you guys so much for having me on. I've known you guys for years, and it's always exciting to get a chance to talk and rage about some of the practices going on in home care that I don't think are reflective of our skill and knowledge as physical therapists, and sometimes more broadly in the rehabilitation space. So I'm a faculty member at the University of Maryland, assistant professor in the Department of Physical Therapy and Epidemiology and Public Health. So I wear hats in clinical world and in the big data epidemiology world and do research in both. I have independent NIH funding as a career development award, and I'm on several NIH and PCORI grants. I'm on grants from the National Heart, Lung, and Blood Institute, the National Institute of Health, that are all related to home care and keeping people at home instead of in nursing homes, which is our hugest value. And I come at this with a lens of a clinician scientist. So I spent several years, 4 or 5 years, as a home care therapist, rural Wyoming, treating steer roping injuries and treating pulmonary disorders at a height of 7,200 feet in Laramie, Wyoming, and driving over dirt roads into the town of downtown Carpenter, Wyoming. And if you don't know where that is, look it up. It's not a town. It is like 10 people that live in a field, but they had a downtown. So I've been experienced as a home care therapist across the country, and it drives my passion because I think there's so much we can do as PTs in this home care space that we're just not doing, and the data that we're relying on isn't maybe as valid as it should be to really drive the best clinical decisions.
So Cindy, you had some.
I'm excited to
go ahead.
No, I'm just going to say I'm very excited to have you here, Jason, and for anyone who's been to a Cornetti and Krafft presentation. Jason is the citation you see at the bottom of several slides with respect to numbers of steps per day, hospital-acquired issues. I mean, we refer to you, so it's exciting to have you in a version of In the Flesh with us today, Jason, to talk about an issue that was triggered by Sherry and I participating in the combined section meeting for APTA this year. We participated virtually, which meant we had access to recordings after the fact. But as I looked through the table of contents, anytime I see your name, I'm like, okay, that one, I gotta watch that one. And the title referred to this issue around frailty, which additionally caught my eye. And as I sat listening to it, I was stunned. I was floored. I was like, Sherry, you have to watch this one. We have to talk to Jason, because, in looking at that information, this idea of frailty in the older adult population, a population that dominates the patient census in any home health agency. One slide in particular, I'm going to refer to it. I have it up. They can't see it, but I can. You talked about the different frailty criteria, things we should be looking for. So issues of self-reported exhaustion, low physical activity, greater than a 10-pound unintentional weight loss, less than 20th percentile of walking speed, and a less than 20th percentile of hand grip strength. And, Oasis geek that I am, a lot of those I was like, wait a minute, that's the item 1033. That's a lot of what's listed as reasons for hospitalization. So if we're already sort of collecting information about it, why are we not making that connection in a care plan? Because Jason, I'm reading these care plans that have generic discussion of a diet or dietary teaching. Here's the same exercise program without resistance that just anybody and everybody gets. What would you want to tell that home health clinician that they need to be looking for, and why does it matter to quantify this and not just say, well, frailty is just, you're a certain age or older, I'm just going to call you frail?
Yeah, well, I think there's a lot to unpack there, but what I'll say is that frailty as a concept is really important for rehab therapists to know. Frailty, we define it as a state of decreased, decreased resilience or decreased resistance to stress, right? It makes you more biologically vulnerable to something like hospitalization, might make you more likely to have readmissions, more likely to have a poor response to therapy. And it would tell us that we should target different aspects in the care plan. So it's totally important to identify it. And I think you're right that those things maybe qualitatively go into this risk for hospitalization piece. But if they have any of those things, you just check that box. That box is, at some point, it becomes a catch-all, right? Where it's just like lots of things that you think are nebulous. And if everybody checks the box, then how valuable is it to guide your care plan? So we've kind of talked about this in terms of physical therapists and nurses should be evaluating frailty separately and have some measure at the agency level. Because things like weight loss by itself is concerning, but weight loss in combination with any two other frailty factors like weakness and slow gait speed, that cluster together signifies, double and triple the risk of vulnerability sometimes in terms of mortality, in terms of institutionalization. So really thinking about patients that have more than one risk factor for hospitalization, when these start to bundle up, that's when frailty really starts to emerge. So a patient with poor appetite or some weight loss that has good strength and walks fairly well and doesn't have a lot of exhaustion is a very different treatment plan. That might be very dietary focused. But somebody who has weakness, slow gait speed, and low physical activity in that frailty cluster, that person is going to need maybe not as aggressive of a dietary intervention, but resistance training is the evidence base for that person. And that's not what most therapists are doing, right? Most therapists are anchoring their treatment based on my research and many others on what we call general conditioning activities, range of motion and kind of standing, balance exercises that aren't really, maximizing the patient's potential. For a regular patient, that's kind of ineffective. For somebody who's frail, you might be contributing to accelerated decline because that patient's already at high risk and you're not addressing their vulnerability by helping reverse that loss of muscle mass. So that person is going to have elevated risk ongoing of readmissions, emergency department visits, of falls. And by not identifying it early, you can't get the right interventions in place. And by not having a place to put it on the OASIS, you can't get paid for that added vulnerability.
But part of that, Jason, fits with, I think, this that we keep missing, and especially in value-based purchasing. I still see such a strong tendency to say, well, the role of therapy in value-based purchasing is to improve ambulation, bathing, and transfers. Or let's deal with the normative composite thingy, and as long as we get some above the line, and it's like, okay. But the biggest reason they expanded it was the cost savings with respect to hospitalization and skilled nursing facility use. So I worry that patients that are presenting this way or checking one or more of the boxes are really being kind of, I'm just going to say it, we're on Unfiltered, not an official webinar, just blown off as old and here's some things and I can't really do much for you and, good luck with that. This is just kind of how it goes. And it's frustrating to read that and say, really, that's all we've got. But one of the things that I should have kept a tally count of how many times you mentioned essentially gait speed. And I still don't find that in the documentation, Jason. I mean, measuring gait speed, it's been called a vital sign. What would you say to folks that are still kind of, my gait assessment is distance, device, level of assistance, and maybe some verbal cue that I don't really tie to anything? If you were convincing me or telling me why I should do gait speed, what would you tell me?
Well, I mean, in Baltimore, gait speed is going to be the indicator if I would tell that patient it's safe for them to walk across the street and go get groceries or not. Just because you can walk 50 feet, but it takes you, you're walking at 0.25 meters per second, a quarter of what we would consider community ambulation speed, you're going to get hit by a car before that light turns. Right. So there's the functional aspects. I live in the city now, and that really matters. I think I also give the example of the person with poor cardiopulmonary endurance who probably can walk 50 feet, but they needed 10 rest breaks and their RPE is 18 out of 20, which isn't functional. It's dangerous to that person to kind of discharge them. My research is on community mobility. And if we think our goals for patients are to be, home, but essentially homebound, and we just discharge them and they can't get out in the community, they can't do anything fun, but, they technically are, not homebound by Medicare criteria, we leave too many people in those gray zones. And so that's my personal preference, but not measuring gait speed. Also, you miss so much information about biological vulnerability. You also miss opportunities to, from a business perspective, you should be able to recertify that person for another 30 days of care. If, their distance increased, but they're still walking below a community or household safety ambulation speed, and their prior level of function was to walk down the block and catch the bus. Too many times we don't get people back to those community points that actually would not make them homebound. And I think there's opportunity to extend home care. Why not do another episode with that person if you can clearly justify, they can walk 250 feet at a less than optimal speed with high rate of perceived exertion. If you document that well, you're well within your justification and well within your rights to add another episode of care for that person. They have skilled needs. And I just think we're lazy with the documentation. And we're on Unfiltered, so I'm going to say that. There's too many therapists that are lazy with the documentation or just bound by historical tradition. And I think there's such huge opportunities to extend home care and use it to the full extent of our scope of practice versus doing, this garbage therapy that just gets people back to the very basics and doesn't actually optimize function.
So what you're saying, Jason, is the Teague train is an old, dilapidated, ancient Amtrak vehicle that goes about 2 miles an hour. And it's time we step on research-based high-speed rail and get it going. I think the Teague, which we see constantly, has its place, right? But adding those elements of the gait velocity and the gait speed is just, it's a no-brainer. But sometimes we get into the recycling, assembly line type therapy, and that's just not good enough.
Yeah,
that's what I'm hearing you say.
And the tug is a tool that has its uses, right? For home care in some small environments, it gives you some valuable information. But if that's the only piece of information that you're using, you're missing the fact that almost everywhere in life that you have to go is further than 10 feet away. So if you're going to go into the grocery store, you're going to teach that patient to be able to go check the mail. You're going to teach them to be able to go back and catch public transit. You walk out to the curb. Those are all skills that take both, high levels of balance. They take endurance. They take functional gait speed, so you don't get hit by a car in the middle of the road. And in some cities, if you don't get across, you are in serious danger because people might not stop. People might, give you a hard time in the intersection. And then we have to think, even just doing this stuff over flat ground is not very reflective of the challenges that many of our patients face walking, on a dirt path or walking on broken and cracked sidewalks in the city. And we as therapists have so much potential, and we do a piss poor job of really meeting patients' needs in terms of community levels of mobility and getting them ready for that as home care therapists. And we have such an opportunity. And I'm saying this in general. There are pockets of therapists who are great, but on average, our administrative and the owners of home care clinics are so focused on profit sometimes that they miss some of these bigger quality of life issues that could be such positive stories and, be great experiences to share with public comment or with new legislation is being proposed to be able to expand what home care can do.
Well, and you both have heard my rant periodically about the infamous to the mailbox discussion.
Mm-hmm.
Having grown up in a city or urban environment for 50 plus years, you kind of lose perspective, I think, about what those distances can look like, because where I live now, it is over 800 feet from my door to the mailbox. Mm-hmm. And going to the mailbox is downhill on gravel. Mm-hmm. So any sort of goal related to that would look very different and has to be patient specific. And I think you're right. It's about what is our value And the more narrow we make it, as if a certain distance is the magical thing and not the underlying other comorbidity and other conditions, we've contributed directly to the environment that now says, if they walk more than X, I'm just not going to pay you. Or I don't know why you're still seeing this 101-year-old person, because it just looks like you're doing these general exercises and don't really have intentionality with it. But I want to touch on one other measure, because gait speed is a whole conversation in and of itself that directly relates to frailty, but you also refer to hand grip strength. What was that connection with frailty? I mean, because I think the rest of it, we go, okay, if I don't eat enough, I've lost weight, I don't have enough energy, I'm weak, I can't walk very fast. But there's one about grip strength specifically.
Yeah, so grip strength is often a good kind of marker for broad, whole body sarcopenia. So low muscle mass, low muscle strength, low muscle performance. It's a decent proxy. It's not a perfect proxy. And a lot of times therapists are already doing other measures that kind of get at limited muscle strength. So grip strength is an example that's used in the formal frailty criteria. But other frailty measures have used something simple like, can you rise from a chair without your hands? Or are you at the normal level of that 30-second chair rise test, which is one of my favorite tests. I use it clinically every time I'm in the Department of Veterans Affairs working with homebound or older adults at risk for institutionalization. We're doing 30-second chair rise on every patient, and we're comparing it to what the Center for Disease Control says is the norms for that age. And if they're below the norms, they're either low muscle strength, and that's a marker of frailty for me. And sometimes just watching that performance one time, I can tell you with pretty good certainty how the rest of that session is going to go, but knowing their lower extremity muscle strength and power. So there's measures that we're already using that give you some semblance of this construct of muscle weakness, which is what we want to capture. Grip strength is one way, but there's many others in our clinical repertoire. Don't use manual muscle testing now. I hate that.
Oh, we can't use our super special eye now for grip strength to go, I think it's this. Or squeeze my finger and I'm a dynamometer now. That kind of
Cindy,
none of that.
3+ and a line down with an arrow.
Yep. I want nothing to do with any of those measures. In fact, I was forced against my will to teach students manual muscle testing in my clinic. So I just found, it has very limited application. It has some uses, but when we have to test it in clinic, I have to do this as part of check off the boxes for students doing training. And I certainly struggle to justify why I would use that for the vast majority of patients when I have much better tools like sit to stand tests or other upper body strength tests that are more functional.
Now, for our listeners today, I want to make sure you don't think, okay, the three of them got on there and bashed physical therapy specifically and say we don't do this and we don't do the other thing. The intent was to rattle cages, which is why Sherry even came up with this unfiltered production idea, is to get us to think, wait a minute, what are we doing? And that was my fundamental takeaway from your session at CSM, Jason. It was like you laid it out, what frailty is, how you quantify it, what are the ramifications to the individual, the system of them ending up back in higher cost care. And I was just literally sitting there with my mouth open going, why is this not the conversation in the home health space? Why are we still going round and round about, I got denied because I put 3+ strength and the person can walk 250 feet with supervision, which I'm like, wait a minute, how do you even have that strength and walk that far with supervision? That doesn't even make sense. Yep. So how do we get unstuck? And I think by further investigating this idea of frailty and quantifying frailty may be a good place to refresh how we're approaching patients, and interdisciplinary, because the nutritional components, all of those pieces could be a great case conference anchor to say, all right, what did we collect about this person? Okay, how many of these boxes did we check? What are we going to do now? How are we going to incorporate this in it and not keep coming with I do med teaching, I do dietary teaching, I take people for walks, I help them get dressed, let's put in a home health aid or not, and really say, can we take not a new idea, but a refreshed idea and reboot our care delivery in these patient populations and say, all right, and I have a reason to continue. I'm not saying do another 30 days because then we get more visits and then no, but there can be absolute justification for this. And I have quantifiable things, not just a plan of care that says continue per POC. So in our final little bit, Jason, where could I go? If I'm listening to this and going, okay, they've mentioned it, I don't have his slides, I get an idea. Is there a web-based resource? I know that there's places to find the gait velocity and hand grip and from a test and measure standpoint, but where would you point me if I wanted to better understand and pursue this quantification and management of frailty in the older adult population?
Yeah, so I would
Besides you directly, unless you want them all to come to you, which, you know, you have a very full plate, so I'm not suggesting that, but where would you point me?
Well, there's a couple of ways frailty is being kind of implemented on a health system level that I think are helpful. You know, there is a 5 criteria frailty scale that you mentioned, the Freed frailty criteria, which is being used, has been used since the early 2000s and been around. And some of the classic papers, which I'll share with you guys, and you can maybe post with the link, or you can put them up on your Twitter pages. But they also have a separate paper about kind of the Venn diagram between frailty as one circle, disability as one circle, and comorbidity as another circle. And somebody can have any one of those things alone, but you really start to get concerned when people have overlaps. When they have frailty and disability together, that added vulnerability would tell you that that person needs a different approach. Or if they have comorbidity, frailty, and disability, and all 3 of those Venn diagrams overlap, which is a lot of our home care patients, that alone should be justification for a little bit more screening, a little bit more intensive interventions, a little bit of a reframing of how we're going to provide care. But those are, doing the Freed frailty criteria is definitely one option. There are other frailty measures that are claims-based. In fact, Medicare and Medicaid services are going to have a claims-based frailty measure that is going to be available in Medicare claims starting maybe next year or in 2025. I just learned about that at my recent conference. So Medicare cares about frailty. They know this is a risk, a risk for patients. They know it's important to measure. So why doesn't your home health agency get way ahead and start to be the thought leader in how does frailty impact your plans of care? Demonstrate that through your patient charts, and then start implementing better solutions to say, hey, look, here's the ideal care pathway. These patients need a little longer, but look how good they do. And then all of a sudden, we've created a reason for a payment differential in the positive direction for frailty.
Well, I want to thank you, Jason, for joining us today. We could go much, much longer than this, but I think you've got us started in the right direction. We appreciate your offer with those articles, and Sherry will get with that and be able to make them available to those folks that are listening to us today. And we look forward to any and all future conversations that include you, Dr. Falvey.
Well, I'm happy to be here for sure. And, I'm hoping it's useful. People can reach out if they need something, to me directly. I'm happy to try to provide resources, but I do think this is an important area. I'm glad you guys latched onto that because it does affect our home care patients, and there's so much we can do as therapists that we're not tapping into.
And thanks again, Dr. Falvey, and those that have been listening, thank you for joining us. And I will provide all the resources that we talked about. And I know there's one particularly good publicly available article on frailty. There was a research article that Dr. Falvey did with several of his colleagues. I will include the link to that as well. So thank you guys for listening, and be safe.